Afternoon once again. Thank you, Choma, for joining us. Choma is joining from Nigeria. Thank you so much. I see Confidence. Yes, Confidence. I see you, and I see Rahila. Rahila is also joining us from Nigeria. Both of them are joining from Nigeria. I want to welcome both of you to this meeting. Thank you, Theophilus, Dami. Thank you, Chidera, Eunice, and UC. Thank you for joining. Okay, guys, let your friends know that this meeting has started. Let us all be in this meeting. We want to see different sides of the conversation. Today is a critical care day. So we are talking ICU nursing in the United States. And the person that is bringing this to us is someone who is very, very experienced in the world of ICU. She'll be giving us all the sides of ICU that we need to know, things that we need to know, how her daily life in the ICU used to be. So guys, get prepared, get your notebook. This is the time for us to kind of have an imaginary feel of what it means to be in the United States. So I want everybody to get themselves ready, get into the spirit of learning, and let us do this together. Different sides of the conversation. We want to see you ask your questions. We also we are here actually to answer some of the questions that you have. So today I have the only and singular honor of welcoming in our midst one of our very own Nurse Yaka Nwufo. Nurse Yaka, you're welcome to this meeting. Thank you so much for joining. And how are you doing today?
Thank you. I'm doing very well, thank you. It's a privilege to be in your midst today.
Yeah, it's actually our own privilege to have you. I know it's very difficult to get you, and I know you are wearing a lot of hats. I don't know how to start, disassembling all the hats that you wear currently because there are so many. But I'm going to save us the stress of going through all your accolades. If you feel and if you wish, you might go through a little introduction of yourself, if you may, when you start. But I know that, Nurse Yaka has been a great support to the Decency NCLEX Academy. She has been with us, I would think from 2017, I guess. And
yeah, 2018.
And she's also still with us. She's currently living her dream in America, in the state of North Carolina. So she's in North Carolina and she's doing great exploits there together with her husband and kids. So she's happily married. Don't come and ask me in my comment box, is she married? Because some people come after the meeting to tell me, are they married? The people that you bring on the program. She is happily married, guys. Look at the comment section, find your wife there. You don't know what happened today. So I was reading in our admin group today. I woke up this morning, I was looking at their conversations, and I found out one of my students was in the class, being very active and answering questions. And another student who was also in the class, they both fell in love, and their wedding is on the 28th of June. So we have any wedding coming up.
Decency Academy wedding.
First DNA wedding coming up very soon. Everything happened in the class. Like they fell in love virtually, began to talk virtually. She has passed her NCLEX. The guy is trying to write his. Both of them are getting married already. So it's possible, guys, but we're not talking marriage today. We are going into the world of ICU nursing here in the United States. So Yaka, just a little intro about, you work in the ICU in the United States, I believe. And I just want to ask you, how is your day-to-day activity like? Like from clock in to clock out of an ICU nurse? It's going to be narrational, so take all the time. Just tell us what it means to be an ICU nurse in the United States. From the time that you clock in, what are the activities that you go through or things that you do when you come to your unit, clock in, and then up until the time that you're going to clock out? What are the activities that you usually perform or things that you usually do as an ICU nurse?
Okay. Can everybody hear me?
Yes, we can hear you.
All right. I actually prepare a little kind of presentation I can to kind of guide me, because if I'm not guided, I can keep talking and talking because there's a lot of things to talk about. So I don't know if you permit me to share.
Yeah, we had a little disruption last week with sharing. So if you can just read off what you have, we disabled our share buttons, because of but if you can read off what you're sharing, and let's go from there. What do you guys think?
Oh, wow.
Yeah,
So this food that I cook, you people will not eat it.
okay, all right, let's do this. Let's try. Let's try and do it. I'm gonna give you access to share now, and let's see how it goes. So try and share now. Let's go. So yeah, yep, you got it. Awesome. Actually, it's a real food that you cooked. We are in. I like people when they come prepared, man. This is it. This is it. Come on. Go on. We are listening.
Okay. So, good day, everybody. My name is Yakamufo. Sorry, let me minimize this thing. Okay. So far I've been a nurse for 10 years and actually working in the ICU. Um,
You want to do,
RN,
you want to do like a slideshow. That way, we see it more clearly. If you click
like a
on the,
slideshow.
yes,
Can you see my screen?
yes, but we are seeing the edges. If you click on the slideshow, we're able to see just your screen.
Oh, okay. Let me go back then.
You see where you have slideshow, review, view, format, design. So if you cannot see your screen, try to flip on your phone. Sometimes you'll be seeing the other pages of your phone. So try to flip back and forth. You'll be able to see the screen. But Yaka is fine. If you're okay, if you're comfortable doing it like this, is also good.
Okay, let me try. Let me go back. Cancel and start afresh. Yeah. Damn. I'm sorry. Oh.
Got it?
Okay, I'm trying to
That's
go
fine.
back.
That's fine. If you can still see your screen, we can still see your screen though. So if you want to continue, that's fine.
Okay, you can see the screen. Should I
Yes, we
take
can.
it back?
Can everybody see the
Okay.
screen on the comment section? If you can see the screen, let us know on the comment section, please. On the comment section, let us know if you're seeing the screen. Can I see yes? Victoria said no. Miracle said yes. So who else can see the screen? Victoria, try and flip on your phone. Yeah, so Theophilos can see, UC can see, it's paused, yes. Yes, it's paused because, yes, it wasn't on slideshow. Go up again, Yaka, keep going up if you want. No, not there. Can you go up? Yes, go up again. Right there where you are, you find the slideshow. Up, up, up. Yeah, slideshow.
This meeting is blocking my view.
Yeah. I see what you mean. Yeah. Sometimes it does that, but that's fine. Keep going.
Okay.
We can
Okay, and now I see your slideshow.
Yep. Yeah. So a majority of our participants can see the screen. So if you're not able to see the screen, just go ahead and try to flip your phone to the left or right. You'll be able to see the screen. You'll be able to see the lecture that Yaka has for us today. All right, so Yaka, go ahead. We are listening.
Okay, so first of all, a nurse in Nigeria. Before then, I did the NCLEX. Before my NCLEX, I was also an ICU nurse. So I was a certified ICU nurse, licensed ICU nurse in Nigeria before coming here to the United States to practice, after passing the NCLEX exam. So I got my BSN here in the United States. And my journey so far, has been interesting. It's fulfilling to nurse having nursed the thought that you want to travel, to come to a different land to practice, a more developed country, and walking through the different process, because I know most of us here have actually written the NCLEX, and well done in your process. I know that there's a lot of waiting, but it's worth waiting, and definitely it's going to get to each and every one of you. We all went through that process. The waiting is very tormenting, but at the end of the day, it's something. After the sleepless night, after the prayers and the fasting and everything, you know, it's a dream come true. So definitely one of these days you're gonna, encourage others as well, because this is a journey people is going to keep on, keying into. So I want to talk about the medical record system. The medical record system we use here. Back home, we do more of digital. Before I left, with the hospital where I was working in Abuja, I think they started introducing the EMR. So some private hospitals are actually keying into EMR. EMR is electronic medical record. So it contains the digital records of patients. So instead of writing on the paper, chatting on paper medications, everything is done electronically. No writing, no documentation. Some documentation are actually done on paper, like consents. If you want to sign consent form, patient does sign consent electronically. Consent for procedures and just some few paperwork. And sometimes we experience what we call downtime. Downtime is when, sometimes, these things are, just like you update your phone will say system update your phone. So sometimes when we go through those downtimes, um it stays for like 2 hours, 4 hours. Then at that time, we have to still do paper documentation. So find out that manual still comes to help, in times where, you know, this system fail. So we have Epic, we have Senna, we have Meditech. These are the softwares that we're gonna be seeing when you come into the United States that we are currently using. Epic is like the number one software right now. Most hospitals are actually upgrading to Epic. Senna is another one close to Epic. Meditech is like one of the oldest ones. Some hospitals are still using Meditech, and it's a new one because I don't know about Cerner, but I've used Epic and Meditech, and um they are very interesting. So for those of us that are back home and we're still doing paper chatting, I will encourage us to at least get the basic skill. No computer, because I know some of us are not good in handling computers. Some of us still has anxiety and phobia in approaching computer systems. So please, the basic thing you can do to help yourself is be computer literate. Anyhow you're going to do it. If you're going to watch YouTube videos, or some our kids are coming up, some of us that have kids right now, 6, 5, 7, 8, they're very good. So be humble to your kids and they can teach you, because you want to come up here. If you have the basic computer skills, and at least know how to type, learn how to type in a moderate pace, even though you're not an expert in typing very fast, but at least in a moderate pace, because you're going to do type patient report, you're going to do a lot of typing. So you're going to do yourself a lot of good, that you know how to at least put your fingers on the keyboard and type, do the basic skills, because you're going to look very funny and very, they know how to, you don't want to look stupid, if I'll use that word, when they are looking at you and you're still hitting the words like one after the other, A, B, C, patient, and you hit it one, and they'll just be looking at you like, oh, what is she doing? So you don't want to look like that. You want to at least get the basic computer skills. So this is a picture of what with like the Epic. Just take a look at this. Actually, this is not this is from Google. I actually have to put the source. So because we don't take pictures of patient documentation, they are very confidential. We don't want to violate HIPAA policies. So this one, I got it from Google, just to show you what it actually looks like. Epic. This Epic is one of the most sophisticated ones and the updated one that people are using, so you can see what it really looks like. So if you look at it, it's overwhelming. Over time you get used to it. So I don't want you to get a look. You at least you are seeing something like ma, you are seeing education, you are seeing care plan, you are seeing charts, you are seeing results. These are terms that you're familiar with, but you see the way they come. So do yourself the due diligence, be computer literate. If you're computer literate, that is just the basic thing you need, and when you come, you see yourself learning, and you flow seamlessly. Okay, so now Bosdi was asking me earlier about the day I see you. So when you come into the United States, of course, when you come in, you are so happy. You are just like this young lady smiling, people are telling you congratulations, welcome to the United States. You don't know what to expect, but of course, it's a dream come true. And then in 2 weeks' time or thereabouts, you are now in the business of what brought you to United States. You come to work. Prior to that time, of course, you would have done some orientation, because they like to, one thing about America, they like to like keep you informed. They don't take you by surprises. They like to carry you along. So before that very first day, you must have come to the orientation, to the hospital to do a tour. They'll welcome you, do a tour, you see your units, you see your manager, you see your clinical educators. These are the people that are in charge of, running the affairs for nurses on the floor. So, of course, sometimes you might even see your preceptor, depending. It's not guaranteed. For why sometimes your preceptor, you see them on the first day. So, regardless of your years of experience, as long as you're an international nurse coming to the United States, they're gonna drill you like they drill their new grads. Just have it at the back of your mind and don't feel offended, because our people, we are in the habit of getting offended at very little things. I just want to let you know they're going to drill you like they are drilling, their new grads, 8 weeks orientation, 10 weeks orientation. Don't feel bad, just get used to it. Even though you are used to computers, some of us are very good, but get used to the system. Make sure, prove yourself. One thing I trust us, we Nigerians, or people from all over the world, we are very good in adapting. We are smart. I've seen people that even don't know computer, grandmothers, people that, women age of my mother, that came here and they are adapting. They are now preceptors. Okay, so you can do this, but I want to let you know that it's actually overwhelming at first, but then you just have to put your mind at ease, and things will begin to come together. So your first day in the ICU, they welcome you to the units. When they welcome you to the unit, sometimes they do a tour, like the preceptors will want to also do a tour, take you around the floor. And then um of course, you have the what we call the orientation shock. Sometimes the preceptors here don't understand our background. They don't understand what it is like for us what it's like for us in Nigeria. That most of some of us is paper chatting, or our documentation system is not as sophisticated as theirs. So sometimes the preceptors will want to, so make them understand where you are coming from. Communication is very important. Make them understand where you're coming from, because if they don't understand, they're going to assume, and once they assume and you're not meeting up to their expectation, they keep giving bad reports, because the managers are going to be expecting feedback from your preceptors. you know how is she doing, how is he doing, is he meeting up to time. Time management is very important, especially in the ICU, because ICU is another zone altogether, not like slow pace like med surg and all that. So they want to know how you're catching things, how your details and everything. So you'll be introduced to different themes. Now, I know back in Nigeria when I was in the ICU, I do respiratory, we handle the ventilators. The only thing we don't intubate, right? But we connect, once the patient is intubated, we connect the patient. Who's doing that? Ebele Ann.
Yeah, I can wipe it for you. Keep going.
Okay, once the patient is intubated, we are the ones that set up the ventilator and connect the patient to it. We're the one that practically wean the patient off the ventilator. We know when it's time. We start the weaning off process. See if the patient is successful and all that. But coming here in the United States, we have what we call respiratory therapists. So the respiratory therapists are the ones in charge of the ventilators. We don't touch it. We don't do anything with it. But what we do as nurses, because a lot of things fall back to nurses. I mean, nursing is like, if you're a nurse, you know that you are in the middle. Like everything, say we have to be careful, and you just have to know, like, you are like the spinal cord of the healthcare system, because the doctors fall back to nursing, respiratory fall back to nursing, nutrition. In nutrition, they'll put in the orders, nursing implement. So we are the implementers. We implement orders, we implement medications, we even implement our own care. So we have our own nursing orders. So when you come, doctors don't put orders. Nursing, we have nursing orders. We have nursing protocols that you get to know and you get to understand, and you have to know when to initiate them as well. So meeting a lot of people, when in Nigeria, you don't see a lot of people. Some does come and go, but then you have a lot of team, case managers that are also, making sure the patients, the bills are paid, that when they are discharged, they're going home right. The pharmacist, you're working hand in hand with the pharmacy, make sure. I remember back then in Nigeria, we do the drug, we reconstitute our medications ourselves. We reconstitute our medications, like patients in the ICU, we titrate those in sedation. We are the one that will mix fentanyl, mix everything together and reconstitute. But here, the pharmacists do that. We don't do it. So you have to know like your limitations, and then having that skill actually give you an edge. So I don't want you to. I'm going to be saying a lot of things while I'm actually talking about our day in the ICU, because it is all encompassing. I want you to know that what you bring to the table is very important. Your skill is very important. It's still very valid. You don't throw your skill as a nurse in Nigeria. Your skill counts. In fact, that's your foundation. And in most cases, it makes you stand out. Our Nigerian nurses here will stand out in our skills because of, the kind of training we have from back home. So, we start the huddle, and your preceptor talks very fast. That's another thing you have to know. They talk very fast. So I put some tips around here. If you look at, I don't know if you can see my screen. If you can see it, I put some tips. You have to learn how the Americans talk. If you go and watch him, if you don't, if you like, if you your kids, that's how you find out. I don't know if you've heard from your friends, or I'm telling you now, our kids do better than us. They cope more faster than us. And, and maybe because they are just kids and we are adults. So you have to just learn how they talk, because, the first 2 weeks, they're going to just be talking. Even your patients, you will not understand. Sometimes you smile back and they think you understand, but you don't understand. You just want the discussion to keep going. But you will not like pretend like you understand, but definitely you don't understand. And then they will ask you, it's time to chat, and it's overwhelming. So you just have to let them know that I'm not used to this before, so they can take time to teach you and answer all your questions. So tech overload, then you see we for ICU nurses, what we see back home, we have the machines, we have the ventilators. Here in America is more than what we experience back home. Like, it's really overwhelming. But over time, I know once you come today, come tomorrow. As you keep coming, you keep getting used to it. You keep familiarizing yourself with it. It's overwhelming. Like the drips, especially like those that are working like in cardiac, you know, ICUs, surgical ICUs, or even any basic ICU, man, the drips there, when you see all the lines and all the drips stacked, we don't usually have that kind of stack back home. Although some do, I know some do, but here is double. So the central lines, these are things we are familiar with, but the foundation you have actually will help you to approach and begin to touch things and get familiar to it. Then the culture shock, back home, I know sometimes our patients, even co-workers, address us with our surname. But here they address you with your first name, right? So you have to get used to being called by your first name. Back when we used to apply courtesy to people like Mr. or nurse this, nurse that. They just call your name. They just call your name. Patient likes to know you. They want to call you by your first name, and your first name is always written on your ID card as well, so they can actually look at it and try to call you. And of course, with our African names, you get a lot of pleasantries. So mostly pleasantries most of the time. Nigeria is well known. At least that's one of the African countries that is well known for in this part of the world. So at least when you may tell anybody you're from Nigeria or from Africa, if you tell them you're from Africa, they want to know further. I tell them you're from Nigeria, from your names and all that. Even from the way we talk, they can be able to tell. Then I talk about the clinical comfort versus curveball. What I mean here is like what you know versus how it's done. So there are things that you know very well. Yes, that thing is good. For instance, the medications, right? The medications, like you are familiar with how the medication is being called. Just like back home, we say paracetamol. Here they say Tylenol, acetaminophen. So it's still the same thing, but the name is different, right? So all those things are the things that we need to get used to. Like, oh, when they say Ativan, but here we say lorazepam back home. So, well, yeah, they will call it Ativan. And sometimes you'll be like, I don't know that medication. But then when you go, because they like to call it, is it the brand name? Here they like to use like the brand name to call. And we call with the generic name. We know that's with generic name, but they call that. So it's kind of confusing. But then when you want to identify the medication, you'll be like, oh, this medication, I know it now. Why are they calling it that? So over time, you get used to it as well. So it just takes time. Everything will begin to sink in. And um then sometimes there's some words that you just like when you have a code blue and they say go and grab the crash cart. And when they say go and grab, because usually in the ICU setting, the crash cart, of course we know what crash cart is. The emergency card is the crash cart is always very close. Like in every aisle, in every hallway, we have one crash cart very close by. Every hallway there's a crash cart. So when they say go and grab, you think that is to go and hold it, like go and grab it. Go and grab means you go and bring it. Because somebody was like, and they say go and grab the crash cart, and she said she went and she was holding on to it, very tight. And they say, what are you doing there? I say bring it. She was like, she don't understand. They say grab, so she thought that she just to grab it, So you just have to, get used to that. I say watch movies and get used to how they talk, so that when you come here, uh there will be, you can able to flow, as easy as you can. Emotional moments, of course, there are some times where it's very overwhelming. I will tell you, it's overwhelming. I've not seen anybody that says, we have different coping mechanism, but I'm actually trying to boost your coping mechanism by letting you know what to expect. It's overwhelming. So a typical day in the ICU. So now you're off orientation. You are now, they're not like, oh, nurse, you are good to be on your own. Go and handle the patient. So when you come in, I advise you clock in early to work. Clocking in early to work, most times it help you to set off your day, especially when you're coming off orientation. You're still trying to, even after orientation, you're still asking questions. Please ask questions. Ask questions. If you're not sure, ask. There are resources to ask the charge nurse, your colleagues. Ask questions, because we're dealing with lives, critical care. You don't want to make mistake, because any mistake, any time wasted is gonna it can cost a life. So you want to make sure you ask questions, and also ask questions to protect yourself. Nursing license, of course, you know what you went through to get your Nigerian license. You know what you're going through right now to, get your NCLEX, the American license, and you don't want to throw it away. So you want to make sure you secure that very well. Legal issues here in America is a very serious thing, and you want to have that at the back of your mind. You want to document. You want to make sure you ask. You want to make sure you know the protocols, so that you can always defend yourself and your documentation speaks for you. Because I've had issues where in 10 years time, 15 years time, patients will go and bring up, the case, and they'll bring it to court, and it's valid, because here they respect people's concerns. And when they bring it up in the courts, they'll start tracing documentations. And if you don't document right, or if your documentation is not there, you know, it starts from you. And of course, you are from Africa. They probe you very, very well. So you want to make sure that you come in early to work. One advantage of coming early to work, of course, coming early to work is coming early to work. Another advantage is that it helps you to like set the pace, help you to like take charge of your environment, help you to go through your patient's charts, and you understand, your patient's history. So by the time you are going to do the bedside reports, emphasis on bedside reports, because some people want to take you out of the bed. Please make sure it's bedside, especially in the ICU. ICU is a bedside report, handoff. You want to make sure you are looking at your lines very well, from the drip as it's hanging like that. You can see the illustration. Where's my pointer? Like this one, you see, you want to trace it down to the patient. And in ICU, we label our lines. If it's fentanyl, you label fentanyl. If it's midazolam, we label. Here they use Versed, not midazolam. So that's another thing. We call midazolam. Here they say Versed. You label it. If it's epinephrine, it is well labeled down, and you trace the line to the patient, because sometimes you find out that maybe the nurse was in a hurry, or the patient was somehow, and she thought she connected it, and the medication is actually dripping on the floor. So you want to make sure that you trace it to the patient, make sure that it's delivering, make sure that the lines are open. Okay, you don't want such situation, because any situation you take over is you. They no longer trace it to whoever went home. It's now you've taken over it. So you want to make sure, if they have Foley's, you want to make sure that the Foley is draining, is well positioned the way it needs to be. Here they're very cautious about CLABSI and CODI. CLABSI, infection that has to do with the central lines, and CODIs are the one that has to do with UTIs. That's the Foley. So you want to make sure you avoid that, because here every hospital in the United States, they are they're like hawks, hawking the central lines, hawking the Foley, making sure that the protocols are being followed. CHG bad. When you come here, you know what, you will see the CHG. Every hospital use CHG. So yeah, you're gonna see the CHG. That's one of the antibacterial wipes that they use for patients that have the central lines. Mostly all patients in the ICU get a bath every shift, so that they can maintain, stay clear from infection. Okay, then after that, after your bedside report, you finish checking everything. If your patient is on vent, you want to check the ET tube. You want to know the settings they are working with, currently the settings you met, because sometimes the respiratory go in to change those settings, and we nurses, we also document on those settings. So we want to make sure that we know what we are working with, we know if you are making progress or not. And after that, we start medications, because the time, once you're in the ICU, you look like the time works so fast. So you're doing medication rounds, you are giving your patient meds. After that, you know medication round from 9 to 10. The teams comes together to do the ward round, what we call ward round. Back home, they do it here. They do their rounds on the patient, they come together. So here, mostly the rounds sometimes is usually like in the conference room, where the providers come together to talk about the patient. Everybody, both the nurses come together, the respiratory come together, nutrition, PT. So it's a whole teamwork come together to talk about each and every patient, the plan moving forward. And of course, after that discussion, they are putting in orders, they are putting in new updates, putting in new medication, and the nurses have to make sure that you are actually carrying out, you know, you're carrying out those stuffs as they are talking about it. When they're putting in orders, you are doing it. They consult, they'll say, okay, let us involve the gastroenterologist, let us involve the cardiologist, let us do that. The nurses, some hospitals, the nurses have to make sure that all this consult goes out. And if there are medication in between that comes in, you make sure they're ensured. And of course, I'm giving an example of a typical day shift in the ICU, like how the day run. Okay, then you have to deal with family members. Family members, they have to ask you questions. Of course, the nurses are always at bedside, so even questions are for the doctors. Even if the doctors answer them, the nurses, you have to answer questions. And of course, here you answer the questions, like you have to make input, you have to educate your patient. They don't joke with patient education here. You education is very important. Every shift we document education, so we have to make sure that you do your education for the patient, the family members. You clear out any misconception. Now when you see that they're asking you questions beyond your scope of practice or anything, you direct them to the provider, or you can let the provider know that this patient has also concerns, also questions, they should come around. Now, sometimes in the ICU, imagine an ICU patient with all the drips and everything, hanging. They have to go and do an MRI. They have to go and do CT scan. So that is another drama show, because it's not just the nurse, the respiratory, the transport. People have to come together to make sure that the patient is safely traveled down, and most times it depends on how stable the patient is. But sometimes it has to be done so that they can able to, move forward. You know, the result of the CT scan, the result of the MRI, determines how the care is going to go. So they have to do it. So you find out that you have to do, the ICU nurse have to organize that transport to make sure that your computers, you'll be beeping beep 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 along the hallway, in the elevator, carrying your patients to make sure that your patient is safe, and bring your patient back. Then documentation. That's you have to make sure you document everything you do. Of course, in the ICU, hourly documentation. Urine output is hourly. Vitals is like every 15 minutes, depending on the acuity of the patients. That one circles, and sometimes in some hospitals it circles and automatically drops in your documentation software, where you can verify and save. Documentation, you have to document everything. You do have to document your conversation. Sometimes, depending on the kind of conversation you have with your patient family, you have to document that the education you give. You have to take credit for everything you do. So that's your documentation is evidence that you did it. So you have to document, and you have to be proactive. Crisis management. Anything can happen. Code blue can just pop up, and then of course in the ICU. So in the ICU environment, everybody is tensed, right? You are not relaxing. Everybody, we are on our toes. And if anything happen, even that nurse that is drinking coffee, that nurse that look like she's sleeping working, once anything is set, even though it's your patient, it's not your patient. If it's your patient, you take charge. You are coordinating. You are giving history. Other nurses actually come. So it's not something you do on your own. So once there's a code blue situation, um there's a team, depending on the hospital, other nurses, respiratory therapy, the doctors. In fact, the whole, is we have the crowd of, the team members at bedside, and the nurses are giving the patient histories. They will ask you, nurse, what happened, what's the patient when you met him, what changed and everything. So you have to, start talking about that. And if it's not your patient, you have to be a team player. you know your BLS, ACLS skill come into play. You have to come in and help, do one or two things. You have to be a team player too. So here they appreciate you being a team player. You don't just focus on me, me, me. You have to, focus on other people as well. You have to, check on your team members, make sure they're okay. If you see anybody drowning and you think you got it, you are good, you go and help. Okay, that's how we do. And same thing happen, and vice versa. And of course, all these things happen, and then it's time to hand off. Okay, then you hand off all the activities to the oncoming nurse at bedside, making sure, even though the nurse don't want to check, please draw her attention to please come back and check. You'll be the one to say, look at it, see how it's going. Some people be like, it's okay, it's okay, it's okay, it's okay, I got it, I got it, I got it, I got it. Please try to draw your attention to make sure that they check and everything is fine before they put something on you and said it was from the day shift or it's from night shift or whatever. So irrespective of the shift you're doing, you just have to um take charge of it. So that's how a typical day in the ICU is. Um, I want to also talk about, like, yeah, did I talk about some tips here? I didn't put some tips here. Okay. Um, so I want to talk about relocation tips. So now you are planning to, I hope you are start putting down your list of things you want to do, and don't feel bad that you are currently in, you're still waiting, because I promise you that this period of waiting, just utilize your time to enjoy everything enjoyable that you can enjoy back home now in Nigeria, because you're going to miss it. I promise you, you're going to miss home. Even though you're going to miss home, you're going to miss those. So enjoy your friends, enjoy your family members. I know, everywhere, um, people are complaining, Nigeria is this and that, but, take your time to uh enjoy home while it lasts. So the for you to relocate, of course, you have to do your credential, your licensing, your readiness, your visa and immigration. Decency Academy is here to always help. Decency Academy is always here. Our boss D is he has an open door policy. He's very approachable to help you in your process, in your confusion. Anytime you have questions you want to ask, he's there to help you. So here I want to also point out that relocation is very emotionally draining. When you come over here, then you begin to understand it's very draining. You want to take time to rest. You want to stay connected with through friends and families. And the stress here in America, it hits differently. The stress hits differently. It's a different kind of stress and pressure altogether. So just imagine the pressure you're going through back home, and you know, imagine it on a different level. That's the kind of stress here in America. So America is good. We are, working towards the dream and dreaming the dream and living the dream. But you have to prepare yourself psychologically for all these follow-ups, because even at work, because in most times at work, nurses, we get drained, like, we work so hard, things happen at work. Few times we hear of toxic workplaces, and of course you don't tolerate anywhere that is toxic. If you find out it's toxic, talk to your recruiter so that you can change, your assignments or whatever it is, but most time it's not. Okay, be cheerful and you'll be fine. Personally, I want to talk about my challenges when I was here. It took me time to adapt to the documentation system, even though I was not a novice in the computer, but the documentation was very extensive because it's ICU and step down. I flew to the ICU, also did step down. So the documentation, due to hourly and everything, you need to make sure you catch up with those things. You are not skipping them. Learning the protocols. We have good eyes. We see, we know how to do the basic things, setting IV lines, all those things. We are very good. We even teach them, but there are some skills that they are sharper, than us. So we just have to learn. And of course, you learn how it's being done here. Nursing is nursing everywhere, but you just have to learn how they do it here in America. Then communication with colleagues and family. I know sometimes the colleagues, when they are discussing, or when they're trying to explain something to you, or when they're trying to even understand you, the pronunciation differs. Okay. um you have to have that in mind. Sometimes the family, find it very hard to understand us, so you just have to take it one day at a time. And then coping with family, work, and childcare here is, on a different scale. So that's it, on its own, is challenging. So how I overcame the challenge, for communication, just try to speak very clearly, because I know some of us, we want to speak like Oyibo, want to change our tongue. The more you try, for we that have the African accent, if you try to do it, you are becoming more difficult to understand. You think it's sounding right to your ears, but it's not. I bet you are muffling it. You are just, changing everything. So it's better you stick with the way you are speaking, but try to speak clearly and audible. They will understand you. Okay, except those ones that, there's some patient that just want to pull your legs, but they actually understand you, but they don't want to pull your legs. But patient, and they love our accents. I promise you, they love it. If you come here, they like the way we talk, because sometimes they are sick and tired of hearing, their own way. So when they hear us speak English and we speak very nice, it's like melody to their ears. They're like, I love your accent, I love your accent. You keep on hearing that, because they think that we from Africa, we don't know how to speak English. I'm like, excuse me, we will teach you English. We speak good English. So when you speak clearly and audible, they will understand you. But when you try to go and form, you are putting yourself in a mess. They will not understand you. So give yourself time. You're going to learn. Stay cheerful. Try to be positive. Here in America, positivity, depression is one thing. It's kind of influential. Depression, the rate of depression here is high, and it rubs off on us. It rubs off on us. So if you're not surrounding yourself with the right people, right friends, it's going to rub off on you, and you don't want that. Burnout is real. Like one adaptation tip I put in there, burnout is very real. You can burn out so fast. To work here is times two. What we do back home is exhausting. Here is more exhaustingly, if there's any word like that. So you want to make sure, please be supportive to your partners. If you're a man here, please support your wife when she come back home and she's nagging and crying how the work is. Please pat her back and support her. If you're a woman, please support your husband. It's the America that we prove through marriage. If you are not married, please plan to marry right, because America will test your marriage. Back home, you can, people endure marriage. People, your marriage is going through, you're like, oh, it's okay. Here, if it gets to here, it gets to here. People be like, you know what? I'm done. They'll be like, think about the kids. You'll be like, the kids will be fine. And my life first. Because at that point, you're struggling to save your life, even over the kids. And you know that the kids will appreciate that mommy is alive, that mommy died, or daddy is alive, that daddy died. So please, be supportive to your partners. Have that at the back of your mind. You need to support your partner. Husband, support your wife. Wife, support your husbands. Childcare, we do it together. For those of us that still have little babies, it's going to be tough. It's a tough and bumpy ride when you come to the United States. Have that at the back of your mind. And you don't want to come and start playing witchcraft on your partner. You don't want to do that. You don't want to do that. It's going to crash your home. Your home should be your happy place. So when you come back from work and you think of, oh, I'm going to meet my husband, you should be happy. I'm going to meet my children. That thought should just warm your heart. So when you are driving home, not when you are driving home, be like, oh my God, should I go to the hotel? Or where should I run away? You don't want your home should be your happy place. So please put God in your homes. Yes, your home be your safe place. Put God first. Very important. Very important. I'm telling you. If not, your American dream will turn to a nightmare. And you don't want that. You don't want that. This is, yeah, I'm almost done. So don't give up on your dream. All the best in your America journey. I'm hoping to see you guys whenever you guys come to the America. You can always hook me up. I'm also approachable. And of course, our boss D is always there for us. And in no time, you're going to be a preceptor as well. It takes like 6 months. You are smart. You are just, before you know it, though, they're approaching you. They're approaching you to be a preceptor. They're already approaching you to be a charge nurse. They're already approaching you, giving you offers and deals that you cannot, you'll be amazed. We are that smart. So believe in yourself and trust the process, and everything is going to, fall in place. Thank you all for listening. I hope I was able to say one or two things today, share one or two things with you guys.
I can't clap for you enough. I cannot. I think it gets better every time in this program. Come on, guys. If you got value for this meeting, kindly go to the comment section. Let's show that we got value. Just type value on the comment section. I want 97 values. We are 97 on this call. I want 97 values. Keep it coming, guys. Keep it coming. Come on. You guys are in for a great deal. See, America has not seen the breed of nurses that is going to be coming from this show. They have not seen it. because you are already getting yourself mentally prepared for the journey ahead. What you're doing for yourself, the investment you're doing for yourself right now is worth $1,000. What is $1,000? Is even worth $10,000 put in your pocket. Come on, what value can you place on a broken marriage that you could have saved? It's worth so much. You don't know what you have gotten today. We are going to dissect these topics that she has, given us today. I don't know, Boss Yaka, do you have 1 more hour to spend with us for discussion? We always have discussion sessions. Do you have 1 more hour?
Okay, that's fine. I'm here.
Okay, guys, you can stop sharing your screen,
Okay.
and then let's get into the discussion, guys. So let me also ask, let me see if we are ready. Everybody on this show, if you're ready and you have 1 more hour for us to discuss what Yaka has brought to our table, please kindly go to the comment section and type, I have 1 hour. Just type 1 hour. Type 1 hour on the comment section. Let's know that we are in agreement, because we're going to spend a quality 1 hour discussing these topics that Yaka has raised. There's a lot of things that she raised. I was just laughing and clapping, starting from the time of grabbing the code cards. There's some terminologies that they use in the US that we're not used to it in Nigeria. So I think one of the sessions that we're going to have, we will add it as part of the things that our guests will discuss, just those terms that people get thrown off by when they are mentioned at workplace. We're going to come there. But right now, we want to just go into a few of what she did. I told you guys she has some pastoral inclination, because when she started doing the marriage counseling at the end of her session, I knew that she was going somewhere. But thank you so much. Now, see, ICU is the place where you give the most med. Is the place where you give the most med in the hospital. So my question to you, Yaka, is how do you cope? Because, when you are talking about tracing lines, they may not understand what you mean by tracing lines. So the drip stand that you see in ICU, it used to look like a tree with different fruits. That's where I see it. Like anytime I go to the ICU, that's how I see their drip stand. They are all like a tree with different fruits, with different color of fruits. You understand? So tracing lines that she's talking about is very, very important. I just wanted us to expand on that. So how do you cope with, I know you said something about tracing the line, but how do you cope with all the mess that is given in ICU? I tell you what, somebody on life support can have more than 10 drips hanging. Each of them needs to be going. How do you cope with all that?
Yeah, like I said, it's really a lot, because sometimes when you come, they're all tangled up. Like they're all tangled up and messy. That's how we differentiate ourselves as nurses. That's how we know nurses that are, well cared.
Thorough.
That's how we identify the OCDs. I
Mhm.
mean, here you see nurses that are priding in OCDs. Nah,
Yeah,
OCDs, hey,
it's a
OCD
disease, but
bukwa.
people
OCD
are,
bukwala, oh, but I don't
yeah,
know how these people are. You see the way they pride. Don't interfere. Oh, allow them
yeah.
to pride their pride.
Mhm.
But they like that perfection. So, but OCD or not, even though your house, you don't arrange your house, please, when you come to that, the tree, just like what this said, it is like a tree indeed. You want to try to make sure that they're actually straight, they are not tangled. So you want to try to untangle the rumble. It's going to help you, it's going to save you time, because sometimes you want to give a bolus, or you want to do something and you have to come into, so instead of that time you used to keep on tracing and unwrapping, so when you come to work, you want to try to unwrap, make sure that everything, all the lines, because they are very tiny. You know how our lines is back in Nigeria, it's the same thing, the same size of tubings, how tiny. And imagine when somebody have up to like six coming from one side and six coming from another side. Sometimes they intertangle amongst themselves, so you want to make sure that they are straight. Another thing that help us with the tape, we have this tape that we put across them, and we put the label of the medications on it. So once you just lift one, you can able to see the tape and know that, oh, this one is connected. You can able to trace it, back and forth. And if it's you that do it, fine. But if another person that do it, you want to make sure that actually that one is labeled, is the one that you don't want to trust anybody. It's not like you don't trust people, but this is people's life you're dealing with. You just want to double check, because you can be saving that person that did it and also saving yourself and saving the patients. So we just, everything, just make sure we go back and look again, and double check. So make sure that we get things right.
That's good. That's good. Thank you so much. Thank you. Another thing I would like to mention, we've had other people on this show. We've had emergency room nursing saying emergency room nursing is the best, is the most stressful, and all that. So the acuity level in ICU, how is it like? How stressful is ICU job? Like for people who are
ICU
hoping
is
to
very
become an ICU
stressful.
nurse.
Emergency, well, ICU is stressful, and it's also people like ICU. Like I can't imagine people like ICU, because most of the time, depending on the level of ICU, so there we have different hospitals here in America. We have the level one trauma, those are like the big hospitals. Like in Nigeria, we say the UNTH, kind of hospital. Then we have this, the mission type, the state hospital, and we have the private hospitals here in America. So those level one ICU, those big ICU, those are the ones that do very big surgeries. Those are the ones the level two, level three refer their patients to. If you're in that kind of ICU, most times their ICU are usually made up of people that are ventilated. They're on the vent, they don't talk. Okay, so ICU nurses like when their patients, they're in control. you know they only stress that they have to stay on their feet, make sure that the drip, the urine, because there's some patients you are like running circles, doing one thing or the other, and sometimes it's just 1:1 or 1:2, because you are dealing, so you don't have to deal with much, okay, but you are busy. And then your patient is not talking. You're only dealing with the vitals. But people, that's why if you take an ICU nurse out of ICU and put them in med surg or step down, they'll be like, please take me back. Because my patient don't talk. And once the patient start talking, maybe the patient is now getting better, they've weaned the patient off the ventilator, and the patient is now talking, making demands. He will start hitting call lights, asking for ice chip, asking for call bell, sorry, asking for phone, asking for different kind of things. Say my back hurts, my ear hurts, my stomach hurts. Then the nurses will be like, oh, doctor, please, time to send this patient out, time to send this patient out. So ICU just like the fact that we are in control. Nobody, the patient doesn't disturb, because all those disturbance, by the time you finish going around, I walked a step down. And I know, understand, by the time you finish doing medication, patient has called you back. Why do you want me? Can you get me applesauce? He asks you for applesauce. You will go to get applesauce. He hit the cupboard. What do you want? I want to go and pee. So you would have said all these things. So ICU nurses just like the serenity of the environment. They control how everything is going to be, but it's very emotionally draining in the sense that after putting all your efforts on a patient, and at the end of the day the patient doesn't make it, or so those things actually weigh down. It can be too much. So that's why we have good support systems to help us to take those things off away, and try not to be too attaching to your patient, because sometimes the family members, they make you very, you're a very nice nurse, you're a very wonderful nurse, they love you so much, and before you know, you have become like a daughter or like a
Mm-hmm.
sister to the family, and if anything goes out, you'll be the one that will cry more than the patient. So cry more than the family. So you want to, try to manage your emotions
Mm-hmm.
in the ICU, because it's very overwhelming. And
Mm-hmm.
of course, yeah, ICU is
Okay.
an interesting place.
Nice, nice. Thank you so much. Thank you. Just to answer your question, Emily. Emily, you're asking about perioperative nurses. We've done that. You can go to our YouTube. Our link is in the comment section. Go to our YouTube. You can watch the perioperative nurse that we brought in this show. All right. I have a question for all the people that are listening. We are still in our 1 hour. Okay. So I have a question for everybody before we come to Yaka again. The question, there is something that happens here in the US, and it's called organ donation. I'm saying this because it happens in the ICU a lot. She just talked about patients not making it even after you have cared for them. So there's something that they do here. When you arrive the US and you go to get your driver's license, they will ask you, do you want to be an organ donor? It's a simple question, but it means a big thing. It means a very, very big thing. If you say, yes, I want to be an organ donor, this organ donor does not mean blood donor. Be careful about the terms. Organ donor and blood donor is not the same thing. So organ donor is like when you are sick and they think you won't be able to make it, they can harvest your organs and then give it to somebody else that has more chances of making it. So my question on the comment section is, how many of you would like to be an organ donor in the US? How many of you? If you would like to be an organ donor, yes. If you don't want to be an organ donor, no. I want to see on the comment section before we go back. I always bring questions for you every time. I always bring questions. So before we go back, I would like to know how many of you that would like to be an organ donor. How many? So you guys you don't want your heart to live when you're dead? You don't want your leg?
You don't want to help people.
I see one person, Jesse said yes. Okay, Maya said yes. A lot of people have said no, okay? And I don't know, do you want to share reasons why you don't want to be an organ donor? We're gonna dissect it. Organ donation is a big thing in the US. It's a very big thing. No way, boss. Okay. All right. I see a lot of no. Someone said, no, I don't want to be an organ donor. What's the benefit of it? We'll talk about the benefit. Okay. And then someone says, I can donate for my children or husband, but not outside. And somebody say, I will go to heaven with my organs. Someone said, no, boss, no way. No one said, another person said, not for me. Then we have another one saying, I don't want to be an organ donor, period. Then I have another one saying, can one donate at a very old age? If yes, then I would like to do. So you don't know when you're going to die. So nobody can donate at a certain age. So you have to say yes, that you want to be an organ donor, and then you'll be an organ donor. Now, if you say no, you don't want to be another organ donor, you will not be an organ donor. You understand? But there's a conflict. There's a conflict that comes in. And the conflict is that if you choose to be an organ donor, what it means is that you are not going to be dead by the time they try to start the process of harvesting the organ. Because if you're dead, the organ will not be useful, right? So if you're dead, the organ will not be useful. So you will still be partially alive. You will be partially alive when the organs will be donated. So this causes a conflict between your choices, and the choices of your relatives. Like Yaka was saying, what brought us to this place is, what you feel at the end of the time, and everybody has decided this person will not make it. And some ICU nurses, they put their life into their job. I've seen very good ICU nurses. In fact, not that I've seen, we have one here with us today. Okay, so when you put your life to a patient's rescue like that, and then the patient is still breathing, patient still has a pulse, patient still has every vital still running, but they have decided, because the patient has signed that he will be an organ donor, that this patient will be taken to the theater, the lungs will be cut off, the heart will be cut off, the liver will be cut off, and all the internal organs will be cut off and given to another person so that that person will live. Most of the relations do not agree at that point. Most of them do not say yes. I've seen an 18-year-old that got into a car crash, but because the license says he wants to be an organ donor, he was taken to the OR, parents, relatives crying, because this is very young child. So I just want to ask Yaka, how do you deal with relatives at the point of death if their significant other is an organ donor, even if they are not? How do you cope with relatives in the ICU? Just that's my question. But it's a food for thought for everybody that is here. When you sign something, make sure you know what you're signing, and make sure you tell your people, your significant other, your wife, make sure you tell everybody around you, this is my wish. So it's not my wish at old age, it's my wish at all times. You understand? So that everybody can honor it. If it is not clearly stated, some people might stand in your way of becoming an organ donor.
Somebody
So
says against my belief.
yeah, I know. I always throw a question every time we meet, and it's things that
Very
is happening here.
controversial one at that.
Yes.
Yeah, the issue about organ donor is something that is very tricky, but then you just have to know your stand and know, like, if you want, you want. If you don't want, you don't want, and let your people know you don't want. Actually, even if you don't want, most times, if the person is a very strong and healthy, viable person, and there's a life on the line, they are the providers, the doctors that are specialized in doing that, prepping the family psychologically, they are very good at what they do. They are good, they are very good. They are very good psychologists. They know how to talk the family into agreeing. Imagine you are say 18-year old. Imagine, like, for 5-year old, imagine for 7-year olds. It's a very heartbreaking situation. Or then, oh my god, if you have experienced, like, because for them to do that, they have to do, like, the what do they call it, they where the whole healthcare workers will line up on this side. The what is it, the glory work or what,
Yeah, glory
right?
work. Mhm.
Yeah, so they have to work the patient. No, the whole healthcare team will work the patient. So actually, it's not the way Boss D put it, that the person is still partially alive. Yeah, actually, before they do, before a patient goes to be an organ donor, he has to be qualified to be brain dead. Okay, that patient has to be brain dead, and for a patient to be brain dead, it's a whole lot of, because once a patient is not viable, they are like, they describe them, those doctors are like vultures. When the vultures see a dead body, and they'll start forming circles. uh, they'll start forming circles. Honor work. Thank
Yeah,
you,
honor
Nancy.
work.
The
Thank you,
honor
Nancy.
work.
Yeah.
Even I don't forget the hair.
Mm.
I say it's glory work. It's honor work, my dear. When the vulture will start forming circles, on top the body, and waiting for the person to die before they will now dive and start eating the body. So that's how it is. They already know when a patient is, and even we as nurses, we know. So if you're an ICU nurse, you know those patients. Like, when they come in, their brain, when you see in those nurses, ICU nurses are trained to do the brain scale, but it's not our judgment that is used to conclude, though. But we do it as far we, as part of our observation, as part of our, skill set and documentation, that this patient is brain dead, right? And then the doctors come around, and then they have to talk to the family that this patient is actually brain dead. So when the patient is brain dead, even, then, it takes time, then the heart shot, so the heart is still, of course, the heart is still pumping, the kidneys, the patient is still making urine, but all those are now under life support. The patient is not breathing on his own, because for patient to brain dead, because the center that control your respiration and the brain, so for the patient to be brain dead, all those things have shut down. And in no time, if the patient is off support, automatically the heart, in no time, they shut down. But then they have to keep them with life support. So the patient is still on pressors, the patient is still on fluids. We are still treating the patient like the patient is 100%, going to make it. But at that point, the patient is, they're just keeping the organs functioning. Make sure the organs are functioning, at a particular point. There are some, the neurosurgery hospitals, they are very good. They have their own special kind of protocols. The temperature the patient have to be, those ones are is another level, kind of ICU. And so, I know understand why you don't want to be. Even personally, I've not made a decision for myself. But when we have life on the line, it's usually like, we have patients that are down with heart failure. Of course, kidney transplants now. A family member can give one and still hold one.
Mm.
Liver now, you can cut your liver in half and give half, and it
Mhm.
will grow up, like that. But heart, that is not two. You know, so sometimes even lungs. Sometimes they transplant even trachea. Yeah, like the level of transport now is, is on another level.
Level,
So
yeah.
so now what you consider is the life of the person that you are saving. So that's what, those psychologists, my sister, those of you that are saying no, if they meet you, they will not meet any of you in Jesus' name. But
Yeah.
if they happen to meet your kind of person with, the mentality you have, you're going to melt. At that point, you're very emotional. At that point, they can even will the family member, they can even will the person in question that they want to give the heart and come to you, and the family members will even be the one begging you, say, please save our son, save our daughter, save our this person, and there's sometimes, if you watch the movie, you see there is sometimes, like, when the person have your heart, you be like, oh, is this person's heart that, your heart, your wife's heart or your daughter's heart is
Beats
actually
in another
beating, is
person.
actually alive in
In
another
another
person,
person.
keeping
Come
the
on,
person
come on.
alive.
Clap for your car.
So that mindset, kind of give them closure,
Right, right.
that, oh, in as much as this person died, but even though he died, he still did good, he saved a lot of lives. Because the way, if a very healthy individual that is very good, the way it happens is heart is going, liver is going, kidney is going, the person is like, it's empty,
Mm-hmm.
like everything is going like that. Kidney
Mm-hmm.
and different, these are the way vultures used to come and hawk, that's how
Mm-hmm.
helicopters will come and be struggling to land.
Mm-hmm.
Like, one helicopter wants to carry the heart straight, the other helicopter carry liver to different part of the states. One is going to Georgia, the other one is going to Texas. They go like that. They are going to save life. They are going to save life. They are going to save life. So the person that, instead of that organ to decay inside the ground, why not give it and let another person loved one live? And sometimes the family actually come together, like they become friends. Some people will not want to know, everybody is different, everybody have the way they process their grief and everything. Some people don't want to know, like, let them stay, we've given them, they're fine, they should do well. While some people will be like, let me come closer. Some of them, it's even the family member that want to come and say thank you. It's rewarding that, even though this person is not alive and doing well, because your loved one gave
Heart.
an organ. So
Okay.
it's actually something that, I'm not saying anybody should process it now. Some people are stern. When they made up their mind, they've made up their mind like that. Some people are very good like that. They are very good in making stern decisions and they stand by it. Why sometimes you just have to consider the lives that you are going to save. And if you're going to save, just like the way Samson died, say, let me die with my enemies. And if somebody wants to die, say, let me die to save lives. It's it's worth it's worth giving a thought. Yeah.
Oh my God. Come on, guys. If you are getting value for this discussion, I want to see you type value plus plus on the comment section. Value plus plus on the comment section, guys. I'm not seeing it coming. I am not seeing it coming, guys. I want to see value on the comment section, guys. Value plus plus value. Okay, you're giving me multiple plus. Thank you. Yes, I want to see value on the comment section. Thank you so much. Yeah, this is real issue. This is real issue that you're going to see when you come over to the United States. And I know that, Yaka had done the work of a psychologist. He has actually convinced some of you, if I'm not mistaken. So, you start preparing your mind. Saving life is something worth doing. I'm not trying to make it, a joke. What they do really save life. If this is something that you're interested in, this is something you should start making up your mind about, because it's gonna come one day. Maybe we are praying that it comes at a later life, like when we are old and old enough, I mean, like very, very old. So, but let's come off from that discussion for a little bit, and then let's talk about the next thing. Okay, I think I'm going to give everybody opportunity to ask their questions now. I don't want to be the only one asking questions today. So if you know you have question, to ask today, I would like you to use the reaction button, not the comment section. Now on the reaction button on your Zoom, just indicate by raising up your hand and I would give you the microphone to ask your question. It has been an amazing encounter with Boss Yakas. Come on, this is very, very enlightening, informative. It's just like it gets better every day. it gets better every day on this show. So come on, I would really want to thank Yaka so much for affording us this opportunity to be with her today. All right, we have Sandra. Sandra Chidima, I've asked you to unmute. You can go ahead and ask your question, Sandra.
So good evening from here. Thanks, Ms. Yinka. Thank you for the time. I'm a registered nurse anesthetist here in Nigeria. I know it doesn't hold a place in the US, but my skill set now, with Westways, I think the first application they made was with one trauma center like that. So I want to know, with my experience, if I can function in the ICU when I come.
Yes, you can function in the ICU and very well at that. Of course, you're gonna be your skill set is you're gonna feel like you're gonna lose it. But then if you feel like you still have time on your hands, you can still move forward to get your CRNA here in the United States. That's another thing that's going to, that's progress. I would have added it, there's a lot of things to talk about. Yeah,
Exactly. You can't finish it in
once we
one
come
day.
here, yeah, once we come here, we try to advance. You see people doing nurse practitioner. So Sandra, I mean, young or no young, age or no age, nothing is a barrier for you. Once you are determined, you can come here, stay in the ICU, because for you to be a CRNA, you have to be in ICU. So still treasure your skill set. Don't lose it. Like, treasure it. Like as you're working now as a nurse anesthetics, I know we are very good nurse anesthetic back home in Nigeria. We are very good at our skill, our hands-on skill are top notch. So just continue doing what you're doing. When you come over here, you work in the ICU. I know you're gonna see a lot of things and be like, what are these people even doing, right? Girl, just give it to yourself, right? And you have a very rich wealth of knowledge. But then when you start working towards getting your CCRN, that's certified critical care, certified critical registered nurse, and then you start to look for ways to get into CRNA. If you prove with your experience, some hospitals can even sponsor you, like they'll be the one to pay your fees. It's very expensive. It's very, like, when you want to do CRNA, it's a full-time program. Okay, so, and it's a very expensive program. So you can actually, what you have to offer, because America, they believe in your experience, right? If you have something to offer to them, they can actually, you can be lucky, God on your side, and then you see a hospital that will, sponsor you to go for the program. So you can be a CRNA when you come here and pursue and still be that nurse anesthetics that you are here in the United States. Yeah, while in the ICU.
Thank you so much, Yaka. Thank you. I hope your question was answered,
Yes,
Sandra.
thank you so much. Thank you, sir. Thank you, Yinka.
And for some of you wondering what CRNA is, a certified registered nurse anesthetist.
Nurse anesthetics. That's the highest paid in America right now.
They're actually the highest paid.
They are the big guys.
It's the blood money of nursing. It's the blood money of nursing. If you really want to really like make the most in nursing, that's where to be. That's actually where to be. So if you want to go that route you're already a nurse anesthetist, but if you want to continue, ICU is the best route. You can never become a CRNA in the US without passing through ICU for at least a minimum of 2 years. So a lot of people you see in the ICU, they're actually eyeing to go for
the CRNA
program.
They are on the road there.
They're on the road. They're just passing through the ICU and getting into the so that's how they do it. So Victoria, I've given you the mic. If you're ready, you can ask your question now.
Okay, good evening, Mr. Decency. Good evening, Nurse Yankee. Thank you for your time.
Good evening.
Thank you, Boss Decency, for your time, always bringing this program to us. My name is Victoria, and I'm in United Kingdom. I just recently passed the NCLEX. I'm a ward manager in orthopedic setting. But I'm still on maternity leave. On returning, I have to just work like 3 months, then I can switch to ICU. But pending on when I'll be coming over to US, do you think I can be able to cope, like switching from orthopedic to ICU? It has been like a ringing question on my head. Anytime I remember it, I think I did like a very big mistake being in orthopedic setting and starting from Nigeria.
You don't like your orthopedics?
I know that I don't like it. I like it, but like before you can venture into something, um, like I like ICU or ER, but I'm thinking of the possibility of like coping when I'm
Okay.
transferring to orthopedic to ICU. Do you think I can easily cope?
Your ability to cope depend on how determined you are. Okay, that something is hard, but you see that people say, Victoria, this is difficult, or it's difficult. You say, I will do it. Is you will do it. And I think you can as well cope, because for you to come into ICU, of course, they don't just say, Victoria, go. They will always want to make sure you are properly oriented. Even in the United Kingdom, even in Nigeria, they want to make sure you go through orientation and able to handle patients on your own, before you can be able to start taking manning a patient care and all that. So if you feel like you want to change skill sets, that is very good. Nursing is a free world. You can always explore any skill set. If you think you're missing out, please don't feel, come out and explore. And if you are determined, you will stay there, you will see what is there, and of course you're going to scale through and do whatever it is you desire to do.
Good, good. Thank you so much. I hope that that answered your question, Victoria. Do we have any other question? While we are thinking about that, if you have question, use the reaction button and raise up your hand, not the comment section. I see some people on the comment section. You have to use the reaction button to raise up your hand. I see a question on the comment section that says, I am going with med-surg, but I intend to divert to ICU. What's the process? So is there any process of coming over,
So the
switching?
process, you going with med-surg. So if you're coming into the United States with med-surg, at least you have to work in that unit for like 1 year. And then you let your manager know that I like ICU. I want to go to ICU. If you're a very good med-surg nurse, they may not want to release you. Another thing is, you have to go to the ICU you like and start talking to the manager if you are really serious. At this point, if you are really serious, you have to come and test the ground and see what it's like in the hospital you're going to be in the first place. Some people will like to try ICU in their hospital. Some people want to change hospitals, like after contract, they want to start on a new slate. But if you think like you like your hospital, you can actually approach the ICU, like the very ICU, the manager. You walk up to their office. Most of them, they are usually very approachable. Like if they have the time, you walk up to the office and tell them you are interested. They like new people. Yeah, anybody new, ICU, well, welcome. They will train you. There's always somebody on ground to train you, there's no process, there's no exam, there's no anything. Just say, I want, and they'll be like, okay, this is okay, so and so time, so and so time. And of course, even if they keep posting you, if you keep coming back and say, I want, I'm determined, you're gonna change. But you try and fulfill that method for at least like a year, 6 months, then you can now switch to ICU. And of course, you can always do what you want. Nobody's stopping you.
Okay, thank you so much. And also, this is not to say that you should not be a good nurse. You said if you're a good nurse, they will release you. So please be a good nurse, okay, regardless. Okay,
Yeah,
so
be a
because you
good
don't,
nurse. Yeah, it's not that they will feel style like, of course, if you leave Nigeria, if you're a good nurse, your Nigerian nurses are going to be crying that you're going to need. Yeah, so
exactly.
be a good nurse also. That will give you the favor. Because if you're a
Yeah,
good nurse, some of the managers will be the one to be like, okay, I will talk on your behalf. Some
yeah.
have done that. So managers will be the one to call the ICU manager to manager. They will make the plans for you. So yeah,
Mm-hmm.
it's good to be good.
Yep, it's good to be good. I like that. Thank you so much. And also, I know that you guys, a lot of people that join us here, they come from different places. So I always want to know where people are joining us from. I would like you to, on the comment section, just state your country where you're joining us from. I know UK is here, Nigeria is here, but I don't know other countries that might be in this show. Because I know sometimes we always think that we just have Nigerians. So I have South Africa, I have Ghana, I have Nigeria. So on the comment section, kindly let us know where you're joining us. It helps us a lot to know our coverage. I have Cameroon, and then Nigeria again. I have Saudi Arabia. Thank you so much, Gambia. Thank you for joining. The reason why I'm bringing this up is that last week we attacked in one of our sessions, and then this week I want to make sure that everybody we're admitting them with their names. So sometimes when I see a strange name, I'm somehow going to let that person stay on the waiting room. So there was a lot of people that had strange name that didn't look familiar to me, and I left it on the comments on the waiting room. So I want to know which country so that we are aware. When I see names, I can research it. If it's names coming from this country, I will let them enter the show. So thank you so much, Liberia. I see you. Thank you, and thank you. For all the people that have joined us, I say a very big thank you to you. I think Bosiaka is gradually coming to her elastic limit, so we will be releasing her shortly. I know some people also had the questions on the comment section. If we have not attended to any of your questions, please kindly raise up your hand with the reaction button, and then we will let you ask your question here. And then from me to Bosiaka, I want to say a very big thank you. We are planning a big round table of all the specialties that we have invited here. Like we've invited theater nursing, we invited med surg, we've invited emergency room, and then we had you right now. So I want to say a very big, who is this? Who is this? Who is this? Again. So I want to say a very big thank you to you. Okay, so for joining us, and then we want to ask that when we slate that meeting, we would like you to be part of the panelists to discuss all what we do in the US. I want you to be part of that discussion when we come to it. All right, thank you so much. So I have Rahila. Rahila is going to be asking her question right now. So Rahila, I've given you the mic. You can unmute and ask your question, and then we would be gradually bringing the program to a close. So Rahila, you can unmute your microphone and ask your question. And then I have Tessie. Tessie, if you are ready to ask your question as well, yeah, you can ask your question too. All right, Rahila, do you have a very calm environment where you can ask your question?
Okay, good evening from Nigeria.
Good evening. How are you doing?
Good evening.
Okay, please, my question is this. How can you prepare your children psychologically with this cultural difference of a thing? Because I learned that even in the school, they face all these challenges, and probably your child is only black in the class and the white children don't want to associate with the child. So how do you prepare them psychologically so that to avoid this emotional trauma on your kids? Thank you.
It's a good question.
Preparing our children psychologically is it starts from we the parents. It starts from how we perceive ourselves, and then what we say to our children. Sometimes it's not really as bad as we think, but as much as we don't want to, we don't desire such for our children, it's sad to see that some of our kids still face this kind of situations in the school where they find themselves. So right now you are in Nigeria. If your kids are up to age to understand, you need to start talking to them. Your kids should be able to know who they are. They should be, they should have that, why you do your prayers together, and why you talk together. Sometimes it's good to like even expose them to like the movies, like within their age, because some of these movies actually show some bully traits and all these kind of challenges that they might likely face, so that they can be aware. Because it's one thing to be aware, and it's another thing not to be aware. So if they're aware that they can expect such a thing in class, somebody coming them to tell them tell them hurtful words, because children are very sensitive. You as the mother, you say this enforcing words yourself. You as my child, you know who you are. Don't let people talk down on you no matter what. And you also encourage them to speak out if anybody says such a thing to them, because sometimes children hide these experiences too from the parents, and even the teacher. So yes, encourage your child. So I believe it all start with grooming your child. Your child should be aware that we are planning to go to this area, especially for children that understand, that now can now understand. We are planning to go to this area, and these are the likely things that you can face. Let the child know, interact with your child. Okay, if you face with this, what will you do? Okay, let your child answer, and then sometimes it's easier said than done, when you are faced with the situation. But it's a good thing that your child should know that my mom actually told me about this thing, and that is that thing my mom tell me, that is what is happening now. I'll go back and talk to my mom about it. Let the school authority, the child should first of all tell the school authorities. you know I think my daughter have come. Somebody who was telling her in class that I hate you, or you are ugly, or something, like one kind of nasty statement. And I told you to say she report to the teacher first. You understand? She report to the teacher, and then she was like, I know myself. I'm not, kids who also want to talk and defend themselves. So, but it's a good thing that we in personally, I would say you imbue that by imbue that, just like preparing your children for war. You are going to war, you have to do this and defend yourself, those kind of thing. We talk to our child when you're in a war front, so your child has to know, because sometimes they face it, that is their own experience. And they but you as a backup system helping them to deal with it will go a long way. So we don't be scared of it, we just need to prepare ourselves for it and pray that we don't encounter such.
Thank you so much. And when you come here, make out time for your kids. A lot of you now, all your mind, all you can think about right now is the money that you're going to make when you come to the United States. It's not all about money. You're going to grow old one day, and that person that you have neglected will be the one to take care of you. There's something called nursing home here. A lot of parents who do not do well, that's where you find them. They'll go there and make girlfriends that are older and all that. They stay there. You understand? But for those people, I've seen children that follow their parents to surgery. Even when those parents are elderly, you see children following. But I've seen parents that come to the OR when I work in the OR, and there's nobody. You say, where is your children? Nowhere to be found. If you call the children to get consent, nobody wants to give time. No, you can imagine your dad is having surgery and you don't even have time to give consent for that surgery. Can imagine how, so that would tell you the type of parenting they had. Some people will cling to you. They will miss work. Some children will, depending on the bond that you create with your children. So it's very, very good that you start from now to begin to be close to them, because they are your how will I put it? They are your treasure in when you become elderly. They are your treasure in your dying days. All right. So thank you so much, Boss Yaka. Thank you everyone that joined us. A lot of questions have popped in, but we might not be taking all. Some questions are asking whether they can move from ER. I think 2 questions were asking same thing, whether they can move from ER to ICU. Bosiaka has touched on that. It is possible. If you come here, you work in the ER, find time to go to ICU after 1 year and ask the manager of the ICU, tell them what you want, and then if they have any vacancy, they can. Some people, you need to have to finish your contract if you're already on contract. Okay, don't let your personal what will I say, your personal vision, becloud your mind of judgment. People are bringing you here, they're paying money for you. If you're signing contract with them, that you're going to stay with them for 3 years or 2 years, don't have in mind that you're going to break that contract. Sometimes it backfires, and it doesn't really backfire very good. Integrity speaks very well. I, for one, I finished my contract back then in 2021. And then Yaka also did the same. Yaka also finished her contract. She came with another agency. So I want to encourage everyone, if you're coming here, if you're with an agency, make up your mind to stay with them, unless there is something that happens and you have a reason to do what you got to do. I also believe in that as well. All right. So thank you so much for joining. I am going to be ending the meeting, but not without us doing our normal last minute ritual. Our ritual, I have many languages here, so I would like us to say thank you in different languages. I don't want to see English, because I know people are from England, but they are not actually from, England. They're actually from different countries. So if you know your language, represent your language, your dialect, please say thank you to Boss Yaka, to her for, being with us today in your language. She will be reading all the languages that we have, I want to see Liberia. I want to see Gambia. I want to see Cameroon. I like learning languages. I've learned Turkish. I can speak Turkish to you guys if you can hear, so I can speak a lot of languages. So I want you to, kind of represent your own language on the comment section. So Rams, you're still speaking English to me. No, there is no God bless you. I want to hear different dialects, different languages. All right. So I've seen one. You see, Midase. That should be Liberia. If I'm correct, please kindly type on the comment section. I think I'm right. That should be Liberia. So please, before we start going deep on that, let us know the country that the thank you is coming from. Let us know the country that the thank you is coming from. Oh no, Midase, oh my God. I missed that, Ghana. I won't miss it next time. All right, thank you so much, everyone. I would like to get some last minute encouragement from Yaka to us. A lot of people who are on this call, they have been faced with retrogression. There's a lot of things, being like a trouble to our mind. We have not really gotten, some people have not gotten through the NCLEX phase. So a lot of things to think about. So I know you've been through this. You were once an international nurse working in another hospital somewhere in another country, but you're here living the dream. So looking down the line, how would you, encourage people who are still struggling to come here? Please go ahead and give us your advice.
Okay, my advice to everyone is just continue to hold on to your faith. That very desire that you know once had, that made you to start off in the first place, or if you're thinking about it and you feel like it's something you want to do. And some people do it for the sake of their children, not for themselves. Some people say, let me do it for my kids, so that my kids can have, so whatever motivation, whatever it is that is motivating you, it's worth it. It's worth the try. It's worth for you to come here and explore the opportunities that are here in the United States, as many. And of course, I know the waiting is very challenging. It's a lot. But take this time you are using to wait, take your mind off it. That's what I would advise. If you take your mind off it, the moment you take your mind off it, you feel better. And then, because you don't want to feel bad, you don't want to feel depressed, because some people will be like, I'm crying, I'm depressed. Complain does not make anything right. That's one mindset I'm trying to build for myself recently. If you keep complaining about something, it doesn't make anything right. But once you accept it, feel better, distract yourself, maybe learn a skill, something that, for the ladies, if you want to learn, if you have baby girls, you want to learn how to make their hair, you want to be good, of course, because you want your daughters to be looking very pretty here. Girls here in America is expensive. Oh, they will collect your paycheck, you know. To keep them, on that good maintenance. So if you want to learn how to make the skill, if there's that particular skill that you feel like you are missing out on, is now you can learn it. It's cheaper to learn it now. You are still back home, wherever you are. It's high time you can invest in yourself and be good at it. Try to distract yourself one way or the other, and before you know it, you see yourself enjoying that thing you are doing. And when they say it's time for interview, you'll be like, oh, should I go for this interview? Even as much as something you've been waiting for. But what I'm trying to say in essence is, when you distract yourself, you feel at ease, and the waiting is smooth. Okay, you are not in distress. But when you are troubling yourself, now, number one, the trouble will not solve your problem, right? The trouble will not make the process go faster. You get? So you just have to try to make peace with everything. Trust God, in our journey of faith, whatever, with respect to all religions that are on call today, you have to trust God, trust the process, have faith that God will continue to see you through the process. Okay? He's our Father. He never disappoints. He knows the best for us. He never disappoints us at any given time. And of course, just like you want your daughter to trust you and your son to trust you that you're making good decisions, this food I cook, I made it delicious for you to eat it. Just like you want that child to trust you, that's how you should trust God and hope that God had your best interest at heart. Just when you take it, hand it over to him and live your best life. In whatever capacity you can live your best life, you live your best life to your fullest. Enjoy this time you're in Nigeria. I promise you, you will remember this thing that I'm telling you today. That when you come here, that's when you remember. You will not remember it now, but when you come to America, you remember that I say, enjoy now that you are in South Africa, now you are back home in Ghana, in Nigeria, whatever state you are. Enjoy these moments. You understand? Take pictures of these moments. Take pictures, enjoy these moments with your kids. If you see your daughter, your son, just keep snapping the picture, because in 2 years' time you will call them. That time they're not acting like American. You come and say, look at you. Look at you when you are eating eba in the sitting room. Do you remember this sitting room? Do you remember this sitting room? You have forgotten. Then to be something of fun. Okay, so enjoy these moments. Know that the future is better. Of course, the future is always bright, and you've done what you need to do. Your worries are not going to solve. You have done what you need to do. So try to be at peace with yourself, be at peace with God, and everything is going to work out perfectly and in no time. Because when you have that peace, you seems like time run fast, and you see everything working out seamlessly for you. And God is going to do it for each and every one of us. Okay?
Wow. Thank you so much. Thank you so much. I really appreciate you, Yaka. Thank you, and thank you. God bless you. I like the way that you tie everything down in, someone having self-fulfillment. You are not where you used to be. You are not where you want to be, but you're not where you used to be. You are moving, you're getting somewhere.
Yeah.
So trust the process that has brought you to where you are, and eventually you will get to the destination. All right. So I want to say thank you. God bless you for being on our show tonight. It is your vendor of good news. And I'm here to also acknowledge all the people that are on this show today. We had almost 130 people on this show. I want to say thank you to you all for joining. And I want to see you next week. So next week, we are bringing people that take care of mad people, okay? So a mental health nurse is going to be with you on Friday, and she's going to be a very funny kind of nurse that you will see. You will hear stories. I tell you stories in between sessions, but that time, I think I'm going to leave it to the person to tell you all the story. So thank you for joining. Same time, same date next week, we are going to be here, and we'll be discussing how the mental health nurse in the US practice their nursing profession. All right, both the clinical and the cultural adaptation as a mental health nurse. And if you think of any other, nursing specialty that we should, bring to the show, please put it on the comment section. I will be here to read them, and then we'll invite them to the show after next week. So we'll be inviting them to the show subsequently. We have so many things lined up already, but I want to get more ideas. All right, thank you so much. I can't thank you enough, Yaka, because you have actually gone above and beyond on this topic. We were thinking it's just going to be, cultural and clinical, but you went above and beyond, and you gave us like a full balanced diet of how ICU is being done, and also how we can culturally adapt to the United States when we come. You have actually enlightened our mind. It shows that you are an educator. I see that thread in you. Thank you so much for doing that, for all the lectures and everything. God bless you. At this point, we'll be bringing the program to a close. I just want to appreciate everyone once again. Thank you. God bless you. See you next week. Bye, everyone.
Bye.
Bye.